Welcome to the NEI podcast. This is Dr. Sabrina Siegel with the Neuroscience Education Institute. Since its inception in 2000, NEI has distinguished itself from other continuing medical education companies by providing the highest quality, visually engaging, evidence-based, and fair balanced activities designed to help keep you on your A game when it comes to treating patients with psychiatric and neurologic diseases. NEI was founded by award-winning psychiatrist Dr. Stephen Stahl, who had the desire to help more patients by helping the professionals who treat them. Dr. Leslie Citrome is clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York, and has a private practice in Pomona, New York. His primary research interests have centered on psychopharmacologic approaches to schizophrenia, bipolar disorder, major depressive disorder, the management of treatment-refractory schizophrenia, and the management of aggressive and violent behavior. Dr. Citrome has also authored or co-authored more than 400 research reports, reviews, chapters, and abstracts in scientific literature. He is also an expert on binge eating disorder. As most of you know, February is National Eating Disorder Month. Please join our interview with Dr. Leslie Citrome, an expert on binge eating disorder. Dr. Citrome, binge eating disorder, or BED, is a very much unrecognized disorder. Could you share with us some of those statistics?
Well, actually, it's the most common eating disorder. So, binge eating disorder has an estimated lifetime prevalence of a bit less than 1% amongst US adults. And this represents actually a higher lifetime prevalence than both bulimia nervosa and anorexia nervosa combined. Older statistics were even higher. And what makes BED, binge eating disorder, quite different is that the lifetime prevalence is pretty similar for men and women, approximately so. About 0.5% lifetime prevalence for men and about 1% and change for women.
Wow. What are some of the warning signs that we should look for with someone who's experiencing BED? What are some of those warning signs?
Well, actually, the diagnosis is made based on two things. Uh, Basically eating in a discrete period of time an amount of food larger than what most people would eat in a similar amount of time under similar circumstances, but also a sense of lack of control over eating during that episode. So this lack of control is very important and must be present. It's not just overeating, it's a lack of control over this eating. It has to occur at least once a week for 3 months and must be associated with marked distress. Now, there's also associated features. So commonly we see eating more rapidly than usual, eating until feeling uncomfortably full, or eating large amounts of food when not feeling physically hungry. And then importantly, eating alone because of feeling embarrassed by how much one is eating and feeling disgusted with oneself, depressed or guilty afterwards. So those are the things that we would anticipate seeing in someone with binge eating disorder.
What are some of the differences between BED and bulimia nervosa? And perhaps what are some of the differences between BED and other eating disorders? What makes this eating disorder unique?
Well, the biggest difference between binge eating disorder and bulimia nervosa is that BED is not associated with regular compensatory behaviors such as purging or excessive exercise or with dietary restriction. Although frequent dieting may be reported with BED, it's not to the same excessive amount as we see with bulimia nervosa. So there's no purging or abuse of laxatives or diuretics and so on. So that's the major difference.
Why do you think it is that binge eating disorder goes so under-recognized or underdiagnosed? Why do you think that is?
Well, this is often a secretive behavior. So binge eating is done alone and associated usually all the time with embarrassment or shame. So it's not ordinarily revealed, and people keep it a secret. And unless the clinician makes a direct inquiry about eating patterns, even doctors won't know that their patients have binge eating disorder. And the food consumption is, accompanied by a sense of lack of control. But if someone walks into the room, it does stop. But it's interesting. It's not unusual for someone to continue binge eating if the phone rings, for example, and the person whose phone call is not being answered will have no idea that it's because someone is binge eating.
And the types of food someone could binge eat with could be even healthy foods. Is that correct? It's not necessarily just junk food.
That's correct. It's whatever food that's around. So, there may be some preferences a person may have regarding the food that they would binge on, and some people would binge on, carbohydrates and, junk food, so to speak. But if that kind of food is not around, people will binge on fruit and yogurt and so on, relatively healthy foods, but eaten in excess is not healthy.
What are some of the organ systems that eating disorders, such as binge eating disorder, can affect? Could you share some of those consequences to the patient's health with us?
Well, there's both a combination of physical comorbidities and psychiatric comorbidities. And even with a normal body mass index, there is a heightened risk for metabolic syndrome. Typically, we see in someone with binge eating disorder some degree of sleep disturbance, pain, gastrointestinal conditions, menstrual irregularities, shortness of breath, diabetes, and an overall low health related quality of life. But psychiatric comorbidities are even more ubiquitous. 80% of patients with binge eating disorder will meet criteria for other psychiatric disorders, such as mood disorders, anxiety disorders, substance use, and attention deficit disorder, for example. Suicide attempt risk is elevated in people with BED, even after accounting for the presence of major depressive disorder. Now, it's important to note that the psychiatric comorbidity is linked to the severity of binge eating and not to the degree of obesity.
That's all very interesting. What would you say would be the best screening tool that's available to screen for binge eating disorder? Is there one that stands out to you?
Well, it's about asking because binge eating disorder is the invisible disorder. It's secret. Spouse and children are often unaware. It's shameful. There's a reluctance to bring it up and also unknown to patients. They may not have heard of it. It's also underrecognized to clinicians, and not all clinicians are aware of this. But every clinician has patients with unrecognized BED. They just come for the treatment of other disorders. So, how do we go about figuring this out? We need to make it routine to ask about disturbances in eating. We already ask about disturbances in appetite and change of weight, both up and down. That's a barometer for general health. But how a person eats is not always a subject for discussion. So, for example, one can simply ask, have you ever eaten more than you intended? And you follow that up with, did you feel like it wasn't possible to stop? So by asking these questions, which quite logically comes after asking about appetite and change of weight, you ask about, well, okay, let me ask you about how you're eating. And have you ever eaten more than what you really intended to eat? And did you feel like it wasn't possible to stop? And then you have it. You have the beginnings of a conversation about potential binge eating disorder.
Right. That's excellent. I love that. What are some of the neurobiological explanations for mechanisms that might underlie binge eating disorder?
Well, that's really a fascinating question with many different possible answers. There's multiple neurobiological explanations. For example, dysregulation in the reward center and impulse control circuitry in the brain. There's potentially related disturbances in dopamine signaling, that is, wanting food, and also disturbances in endogenous mu opioid signaling, and this represents liking food. There's also interplay between genetic influences and environmental stressors. For example, there are functional polymorphisms of the dopamine D2 receptor gene and of the mu opioid gene that may influence the proneness to develop BED. Now, of course, there are many psychological antecedents to binge eating and binge eating behaviors, including negative affect, interpersonal stressors, dietary restraint as well, negative feelings related to body weight and body shape and food, as well as boredom.
When does BED become an obsessive compulsive disorder?
Well, binge eating disorder has an obsessive compulsive component, and we knew that going into all the trials for interventions for BED. And so, what is typically measured during clinical trials is the Yale Brown Obsessive Compulsive Scale modified for binge eating, which measures both obsessive thoughts and compulsive behaviors regarding food specifically. So, it's part and parcel of the disorder. The disorder's behavior is binge eating, but underlying that binge eating is disordered thinking and, of course, disordered behavior.
Very interesting. What are some psychological treatments that are effective and available for the treatment of BED?
Well, both cognitive behavioral therapy and interpersonal therapy can reduce binge eating behavior. However, access to these treatments can be limited because of local availability or cost, and not everyone is interested in the really the hard work that goes into CBT and IPT and requires some degree of psychological mindedness. About a third to half of patients with BD also don't appear to benefit completely or sufficiently from psychological and behavioral treatment. And another caveat, although for some patients this is the ideal treatment, there is generally little or no weight loss. Although successfully eliminating the binge eating behaviors can protect against future weight gain.
With that, then, are there any effective pharmacological treatments that are available for BED?
Well, many have been tried and many have not worked out. There is, however, an agent approved by the FDA for binge eating disorder, and that's lisdexamfetamine. And there's another one in phase 3 of development for binge eating disorder, and that's dasotraline. Now, lisdexamfetamine is a stimulant, and dasotraline is a dual acting dopamine and norepinephrine uptake inhibitor. And lisdexamfetamine available today for this use, and dasotraline in front of the FDA. I just want to keep in mind, though, that the many other treatments were tried and failed in terms of robustness of effect, tolerability, or both. So examples include antidepressants, which can reduce binge eating frequency, but may increase appetite. And anticonvulsants like topiramate have been efficacious in reducing binge eating and in reducing weight, but has a negative impact on cognitive function. Anti-obesity and anorectic agents have been tried, but have not been successful. Naltrexone has also been tried, but not generally successful either. So the tried and true treatment is at present lisdexamfetamine and in front of the FDA dasotraline.
Excellent. Well, it sounds like there are some potential treatments that could be very effective, and that is exciting news. I want to thank you so much, Dr. Citrome, for joining us on this episode of the NEI podcast.
You're most welcome.
This episode has been brought to you by NEI Synapse. Register now to take advantage of early bird rates. They'll only last through February 15th, so grab your seat now. Go to www.neiglobal.com. We'll see you there.